The most frequent indication for corneal transplantation in the United States is endothelial failure. According to the Eye Bank Association of America, 85% of all grafts in the United States were performed for endothelial disease. Recent advances in endothelial keratoplasty, or EK, the selective transplantation of components of the cornea instead of full-thickness keratoplasty, have revolutionized the treatment of endothelial diseases. EK has been demonstrated to provide faster visual recovery, minimal astigmatism, and an improved safety profile compared to traditional penetrating keratoplasty. Techniques and nomenclature in EK remain in evolution. Descemet stripping automated endothelial keratoplasty, or DSEK, is the preferred EK technique worldwide. In this procedure, pioneered by Drs. Mellis, Terry, and Price, host Descemet's membrane is stripped and a donor tissue consisting of posterior stroma, Descemet's membrane, and endothelium is inserted using a variety of techniques. Despite DSEK's advantages, studies have shown that fewer patients than desired achieve visual acuity better than 20/30. Dr. Mellis described a technique for transplantation of only donor endothelium and Descemet membrane called Descemet membrane endothelial keratoplasty, or DMEK. DMEK series have reported superior visual results and comparable endothelial cell loss as DSEK. In our DMEK technique, a pre-dissected donor cornea is obtained from the eye bank, and the donor Descemet membrane is prepared to the appropriate size using a standard disposable trephine. The host cornea is prepared in a standard DSEK technique by scoring and stripping the pathologic Descemet membrane, followed by scraping of the peripheral 2 mm of the host bed using a Terry scraper in order to promote graft adherence. Our simple device is constructed using a disposable 10 cc syringe, IV tubing, and an alcon B cartridge. The IV tubing is cut using drape scissors approximately 2 inches from the hub. We make an effort to make a steep angled bevel. The cut end of the IV tubing is then inserted into the rear of the alcon B cartridge. The fit is quite snug, and we make an effort to advance the tubing as far as the cartridge will allow. The IV tubing is then connected to a pre-filled syringe, and balanced salt solution is then infused through the device. The tip of the device is placed next to the DMEK graft, and the graft is gently aspirated into the device using negative suction. The device can be inserted into the anterior chamber through a standard 2.75 mm keratome incision. In this case, a scleral tunnel incision was used, but a clear corneal incision can also be used. The tissue is delivered by gently depressing the plunger of the 10 cc syringe. Be sure to continue infusing as you remove the device. The tissue can be challenging to unfold, and in some cases we place an air bubble on top of the tissue. Once the tissue is in good position, the air bubble on top of the tissue can be aspirated, and we replace this with a full airfill from underneath the donor tissue. The device is simple and effective, but be sure to use an alcon B cartridge and not the larger A cartridge, as this causes too much leakage from the rear of the device and also from around the wound, as you can see in this video. We prefer to cover both eyes for 1 hour in the postoperative waiting area.
You can do what you want. The opportunity's on.
Our early results support the advantages of DMEK, and we hope that our simple device, which is available in every operating room, will make it easier for willing corneal surgeons to transition to this new procedure.